Good morning, everyone. Sorry that we are not together on the beautiful shores of Lake Superior, but appreciate you taking the time to join for this special annual meeting. So I really appreciate the opportunity to say hello and also to say thank you for the work that you have done, continue to do in this incredible experience that we have had together and are still having, steering our state and our communities through a global pandemic of proportions that few of us, I think, could have really imagined. So my task in the next few minutes is just to sort of very broadly touch on some of the themes of the conference that you'll be exploring in your workshops. I'll give you just a short report on the pandemic, but spend most of the time hopefully teeing up some thoughts about where do we go from here? What have we learned and how can that inform our redesign efforts? So Zora, if you can pull up the slides, we'll dive right in. And I think the conference name is well taken, charting our course. And certainly it does feel like we've been some of those early explorers trying to figure out where we are without a lot of guidebooks, given the unprecedented nature of this global pandemic. Next slide, please. We're going to talk really about sort of briefly about the response and where we are now in terms of a recovery phase. But I think the purpose of the conference is largely to talk about resiliency and redesign. Even though we're all incredibly tired, I know, this is also just an incredible opportunity to harvest as quickly as we can the lessons of this pandemic and put them to work in redesigning some of our systems and advocating for policy changes that will put us in a stronger position going forward. So as I mentioned, this has really been pretty uncharted territory for all of us in so many ways. The fact that this pandemic spread so quickly around the globe is just a powerful reminder that indeed the world is increasingly a small place and very connected. And it's really true that anything that affects any part of the world can be right in our backyard within 24 hours or so. And we saw that with this pandemic. And certainly our state's emergency preparedness system, which is something we've worked together on between healthcare and public health for many years. This was a test of its thoroughness and its durability. I mean, one thing that's been really unusual about this pandemic, even compared to things like the 1918 flu, is the duration of it. Even though the 1918 flu lasted, a couple of years, at the local level, it was really a several month phenomenon. And we're now into a solid year and a half of dealing with this in all of our communities. So not only was this a stress on healthcare and on public health and our emergency preparedness system, but it also tested and really required us to step up our game a whole new level on collaborative relationships. And I do think that's one of the bright spots emerging out of this that we can build on for the future. Next slide, please. And I really have to say, I think our legislature in Minnesota has been just superb in terms of it reacting very rapidly. In March, when we began to see our first cases, the legislature very quickly authorized MDH to award $200 million in grants in two separate streams, a $50 million and $150 million grant fund to support the capacity of eligible organizations within the continuum of healthcare delivery to plan for and prepare for and respond to the outbreak of COVID-19. Certainly that was sort of the down payment. I think we all knew that would not be enough, even though that's a lot of money spread across our entire healthcare continuum all across the state. That was critical early money, but we're also very grateful that the federal funds that began flowing then and are continue to flow now have been literal lifesavers for some of our healthcare institutions. Next one, please. In terms of how the pandemic has affected the state, even though we know the population split between urban and non-metro areas, the pandemic, in terms of cases per 100,000 people, hospitalizations per 100,000 people, and unfortunately deaths on a population basis, rural Minnesota actually has fared a little worse than the metro areas adjusted for population in the later parts of the pandemic. Early on, certainly the first outbreaks were in the larger metro areas and in some rural areas of the state where some of the first workplace outbreaks we saw, of course, were in the food processing plants. So rural Minnesota, greater Minnesota, definitely experienced some of the effects of the pandemic early on, but that just built over time. And it's certainly in terms of general population concern and awareness, maybe took a little bit longer for some of the counties in the state to feel that COVID was an issue for them. But indeed, it became truly a statewide experience. Next one, please. We're going to come back to vaccines in a moment here, but one of the things that absolutely, without a doubt, helped us really avoid a worse surge of COVID cases that started to build in late March and April. It was looking for all the world like that spring wave was going to match or even exceed the big surge in cases that we saw in the late fall, but it didn't. And the reason it didn't is because of the success we had in vaccinating some of our most vulnerable populations early on. So vaccination was clearly a key to having avoided what could have been a really truly catastrophic wave in the spring. But you see here that a non-trivial gap has emerged in the vaccination rates between the Twin Cities metro area and the balance of greater Minnesota. You can see there that we're now almost at 73% of the over 16 population with at least one dose in the greater Twin Cities area, but just over 58% in greater Minnesota. So that remains quite a concern, and would love in the discussion period to get your advice, your ideas. How can we help each other try to close this gap, because it's urgent. It's time critical given the spread of the variants that we're seeing around the world and in the US and here in Minnesota. We've got pretty much all the variants here already. So this is really an urgent task. We'll come back to this point in a little bit. Next slide, please. Next one. So where we are currently, it was March 6th of 2020 when we had our first laboratory confirmed case, and the person with kind of retrospective case investigation had developed symptoms a few days before that. But early March is when COVID officially arrived in Minnesota. And of course, we believe it was here quite a while before that. But in terms of laboratory confirmation, diagnostic confirmation, I remember that press conference very well on March 6th of 2020. And since then, we've been talking about the numbers every day, and sometimes you can get a little numb to the numbers when you just keep seeing it over and over. But we can never forget that we've lost over 7,500 Minnesotans to COVID-19, and that's just, again, the confirmed cases. There are many more that may have been COVID related, probably were, but the ones that had confirmatory laboratory tests. And those deaths continue, thankfully, in lower numbers all the time, but we still have a lot of folks at risk. Over 604,000 cumulative cases, again, with laboratory confirmation. We know the true numbers are probably 2 or 3 times that number in terms of folks who actually had COVID but were either asymptomatic or mildly symptomatic or just never got tested. Over 25,000 people hospitalized, but now in the last probably 6 weeks now, we've seen really significant and sustained declines in the number of cases, the number of hospitalizations, and the number of deaths. So, we definitely are in a much, much stronger position now. And we're seeing case levels and hospitalization levels as low as they were since April of 2020, when we were heading upward on that slope, not really knowing what we were facing. So we've got so many more tools now in our toolbox. And certainly, the numbers are showing the dramatic impact of vaccinations, especially in some of the higher risk populations. Next slide, please. So this is just a chart of kind of what the vaccination rollout was designed to be, and you are certainly familiar with this, starting with healthcare personnel and people, residents of long-term care facilities, really with an eye toward making sure that the workforce that needed to care for folks was protected, and that folks in those congregate care settings where we had seen such devastating impact of the pandemic early on, that those were the first groups to be protected. And then we began, opening up to other critical workforces like the pre-K through 12 education and childcare staff. And then in fairly early, middle of February, the federal government actually sort of preemptively said, we're going to open up to all people 65 years and older. So there had been a more kind of complicated prioritization schedule that the federal, the CDC's advisory committee had that we had adopted and tailored a bit here in Minnesota. So we had imagined, a longer period of time in which we were really needing to prioritize population groups and did so around age and underlying conditions. We really did have, several months where the demand for vaccine far outstripped the supply. And that was a frustrating experience for our people, and I'm sure for you as providers to not be able to vaccinate everybody who wanted or needed it early on. And then we had, really was only about 3 weeks, literally, where our vaccine supply and the population demand were really quite well matched. And we saw very rapid vaccination pace, really high demand, and enough vaccine in the right places to basically meet that demand. But that didn't last long. And kind of surprising to a lot of us. I mean, we always knew that the pace of vaccination would slow down. We didn't expect it to literally like fall off a cliff quite as soon or quite as fast as it did. And that was a national phenomenon, really, not just here. But that since sometime in mid-May, we've really seen the progress in vaccination be much more incremental. We used to go up, several percentage points in our vaccination rates a week, and now we're going up maybe 1/10% on most days. So it's really slowed down, and that chart a few slides back really visually showed that, how the growth curve in vaccinations has flattened. And that's true pretty much for all age groups, except for the newest eligible population, the 12 to 15-year-olds. We've been really pleased to see the uptake in that population. We're already above 30% of 12 to 15-year-olds vaccinated in a fairly short time. So that's great. And we look forward to the approval we assume sometime, in the not distant future of the vaccines for younger people as well. Be really critical to get as many school kids as possible vaccinated before the start of the school year. So this just kind of shows kind of what the progression was intended to be, and it did kind of, go wide open at the end of March. Again, sort of federal, with a federal push, but we actually had made really good progress by that time, and so Governor Walz opened up eligibility to everyone over 16, a little bit ahead of the federal target for doing so. Next one, please. So where we are, and I guess according to the slide, this is as about a week ago, just under 3 million. I think we have now, I think, passed the 3 million person mark for at least one dose. So we're probably over 66% of folks with at least one vaccine dose now. And a pretty solid majority, like 92% of those with at least one dose have had a complete series, whether that's just the one dose Johnson & Johnson or both doses of Pfizer or Moderna. And so we, as you probably know, the president has set a national goal for 70% of everyone 18 and over to have at least one dose by July 4th. We're in, not saying it's a slam dunk, but we're in pretty good shape in Minnesota to meet that goal. We're only 1 percentage point away from that 18 plus goal by July 4th. But our Minnesota goal has been 70% of everyone 16 and over to have at least one dose by July 1st. And we are not going to make that. We hope that we will get there sometime in July, might be early August, but that's just another milestone. We don't stop there. We need to get as much of the population vaccinated as we possibly can, especially because of the variants. Those pockets of communities that are less vaccinated remain at high risk for disease and bad outcomes. And now it's literally over 99% of all the people who are hospitalized are people who have not been vaccinated. We do have breakthroughs, of course, as you know, but the overwhelming correlation of regions of the country or of our state with lower vaccination rates are where the case levels are still much higher than is true for the general population. So, keeping on trying to get people good information from trusted folks, that's you, to answer their questions about the effectiveness and the safety of the vaccines, and making the vaccines conveniently available to folks where they are. Increasingly, the pharmacies are doing over half of the vaccinations on a weekly basis now. And we think, the healthcare providers and sort of in the normal clinical operations of primary care and other points of care will be the place people want to get vaccinated. And certainly that will be true for the younger kids, especially parents wanting the advice of their pediatricians or family physicians to do that. Next slide, please. So certainly one of the things that we knew before COVID, but has been just further illuminated and exacerbated by COVID is our health inequities. And there's not a single community that doesn't have health barriers and health needs that are specific and unique to that community. But certain populations were hit just much, much harder in terms of exposure risk, but also severity of disease and poor outcomes. And certainly we know that there was a strong, strong correlation between age and hospitalization and death. Once you get everybody over 50 vaccinated, you've accounted for some 95% or more of all the hospitalizations and deaths. And that's, again, part of why we avoided a worse spring surge, is because we had pretty good coverage rates in the very, very good, well, best in the nation practically for 65 plus statewide. So the older population certainly is one group. But also lower income workers, a lot of the kind of the critical workforce that didn't have the opportunity to work from home and often were working in close conditions, the food processing plants just being an example. So that some of those folks had a disproportionate risk, and certain racial and ethnic groups have been hit especially hard. Some of those, again, and it's a combination of exposure risk due to both their occupations, their living conditions, their difficulty in accessing healthcare, in not getting tested at the same rates, and now not getting vaccinated at the same rates. So the populations that have been the hardest hit are also some of the ones who have not had as easy access to vaccine. And we are trying to adjust our outreach strategies and our models for delivery of vaccine to reach those harder to reach or hardly reached populations. And I know that that's true for our healthcare systems as well, working to get deeper and deeper into communities. Next one, please. This is a picture that correlates high social vulnerability index zip codes with vaccination rates. And I don't know if everyone's familiar with what the social vulnerability index is, but this is a CDC developed measure that looks at 15 different elements to come up with an overall social vulnerability index score, if you will. And you can break that down to the zip code or census tract level. So what's going on? This is a busy slide, I know, but the red tones are low vaccination rates, and the blue tones are high vaccination rates. And the darker the color, the higher the social vulnerability quartile. So we report all of our data now sorted by quartiles of social vulnerability index. And you can see there, we got a lot of dark red, which are low vaccination rate with high populations in that social vulnerability index category. So what we know is that the population living in the higher social vulnerability index quartiles have much higher case rates and rates of hospitalization and death. So SVI quartile 1 has accounted for about 40%, we believe, of the hospitalizations and deaths, even though their share of the population is more like 20-some%. And you can see, so that, and then the darker blue, again, the high vaccination rates, and you can, in the metro area, you can drill down a little bit further to see how that maps. This is not a terribly helpful map because there's too much going on in it, but on our dashboard, our vaccination dashboard, there's a lot of really good information kind of broken down at a regional level about both the population composition and the vaccination rate. But as vaccination is slowing down now, just all the more important that we redouble our efforts to reach folks who are at the greatest risk, whether that's from many of the measures that compile this social vulnerability index, which is income, housing, transportation, race and ethnicity, just a whole bunch of different variables that have shown to be a pretty darn good overlay with disproportionate risk for exposure, as well as pre-existing health conditions that lead to poor outcomes and the like. Next one, please. So transitioning now into a little bit more of sort of how has this impacted healthcare? Well, again, there's just no way that we can ever, that Minnesotans can ever thank our healthcare providers enough for what you've done and what you've been through, the role that you have played in not only caring for people, but also trying to help educate people and help to turn the tide on this pandemic. And the impact on you personally, professionally, not only in your practices, but your personal impact on you and families has been enormous. There is a lot of trauma that's been caused by so many dimensions of this pandemic on our healthcare providers. And it's important that we acknowledge that and deal with it and try to get resources deployed to just help deal with that. And I'll say that's very true in the public health workforce as well. A lot of exhaustion and a lot of genuine trauma dealing with this much pressure and this much loss. Next one, please. So how are we going to come back? How are we going to harvest some of these lessons and learn and move on? Next one, please. I do think that the pandemic, what's that phrase? Necessity is the mother of invention. We had to do a lot of things differently and quickly. And I think it did push us to do that. It also helped highlight some of the strengths in our system. I cannot say enough about the collaboration that happened among providers in all regions of the state, through the regional healthcare preparedness coalitions, through MHA, through coalitions of healthcare providers, through the Care Delivery Consortium or coalition. We watched everybody really pull together to make sure that we were moving patients around to the level of care they needed. The State Healthcare Coordinating Center and the Critical Care Coordination Center, the SHIC and the C4 were just enormously valuable tools to help make sure that we were using all the resources in the state as efficiently as possible. As well, the way you work together on vaccination, especially in those frustrating early times when there wasn't enough vaccine to go around, and it was important to try to prioritize to get at some of those highest risk group first. And the way that the coalitions worked together to do that was really wonderful. And I think, we've got, and I think there was more collaboration also across the continuum of care and between healthcare and public health. I've heard from many of our local public health colleagues that their relationships with their local healthcare partners has never been stronger than it is now. So I hope that is something that we can really build on going forward. Next slide, please. And certainly from a coverage standpoint, and this is, hats off to the Department of Human Services and, to good policy decisions, I think at the federal and the state levels to make sure that people didn't lose coverage during the pandemic. We know how important it is that people be able to get to the doctor to be treated. And we've, even though I think some people still are hesitant to get testing or get vaccination because they think it will cost them. That's been a message that's hard to really get out adequately, that there is no charge for state-sponsored testing and for vaccinations from any provider under the federal rules. So both those specific interventions, but being able to get care, not only for COVID, but for everything else. And we certainly are seeing now, as you predicted, the impact of delayed care, people not getting some of their usual preventive care or care for chronic conditions is showing up in the greater severity of hospitalized patients for things other than COVID right now. But we did not see an increase in the number of uninsured during the pandemic, and that was a very important and a blessing. Next one, please. Well, we did certainly see some weaknesses in the system. Definitely, this again, not new news to you, but I think the pandemic definitely underscored some of the workforce shortages that we have, especially in some of our smaller hospitals, and especially in congregate care settings, where when significant portions of the workforce were ill or quarantined, I mean, it literally made continuing operations impossible for some without emergency, crisis staffing support. And that, so that's been true really across the care continuum, but especially exacerbated in long-term care. Next one, please. We also know and have again, knew it before, but this is really, really, really underscored it as well, how important communicating in ways that are specific, that meet the specific needs of communities. That and the same message and the same messengers and the same content does not work for all communities. That we have to have everyone be fully informed about testing and vaccine and risks, and to counter the misinformation that is very prevalent in some communities, including for some pretty understandable reasons, unfamiliarity with the system or past history, where vaccinations, sponsored by the government especially, are something not to be trusted. So getting that information out through trusted community leaders and community organizations that people do trust and are familiar with. So whether that's language translation, but even more importantly, kind of culturally specific knowledge of what are the questions, what are the issues, and how do you effectively communicate about that. And we've been able to really beef up our grants to community-based organizations who are serving as resource coordinators for their communities, much more work with cultural media, and much more kind of awareness that just written communication is not sufficient. You can translate everything into all kinds of languages and still miss the mark if you're not communicating in the ways that are the most relevant to a community. Next one, please. So back to the workforce shortage again a little bit. This just shows kind of what is the supply, the number of physicians per 100,000 people. The bright green, as you see there on the right, metropolitan areas, large towns, small town rural, and then the dark blue isolated rural. And you can just see there, the distinctly lower supply, particularly of some of the specialty areas, with the exception of general surgery, and in terms of family medicine. I think that clearly the family medicine docs are really the backbone of the healthcare workforce in our smaller towns and isolated rural areas. And this picture is changing over time, and you can really see it through the lens of certain kinds of capacity, which I think is coming up in a couple slides here. Next one, please. So we know about this. We know that the workforce challenges have been with us for a long time, and they're systemic, and they're not a short-term phenomenon. So we need to continue to push on all fronts to expand scope of practice for professionals working in shortage areas, and to create new professions that meet rural needs better. Things like the community paramedic program and the dental therapist have been a great innovation and really show great promise in promoting rural health. Getting more clinical training sites in rural areas. We know how important that experience is to health care professionals thinking about where they want to practice. They tend to practice where they train. As well, the importance, value of healthcare loan forgiveness and repayment programs as an incentive to practice in some of our more underserved areas. Next one, please. So switching a little bit to some other kinds of infrastructure issues, technology. I mean, we saw more advancement of telehealth, tele-everything in the first 6 months of the pandemic than we had in the prior decade. And now we need to really assess which uses of telehealth were the most effective. Probably varies a little bit by type of issue and type of care. So what should be the standards going forward for the most optimal use of telehealth, and how do we make sure that that's available? And it really could be a great extender for some types of care in rural parts of our state. For instance, chronic condition management might be really boosted by telemedicine, but we need to know what works, what are the standards, how is it paid for, and of course, statewide broadband is awfully essential to making telehealth really available and robust enough to be reliable for clinical purposes. Next one, please. I think I pretty much covered this one already, and I just think that there is a lot to dig into here. And this is a national conversation. Like, okay, what kind of data have we gotten through over the last year about the impact of telemedicine, and what can we learn from that? There are going to be national discussions and studies on that. The legislature, who is not done yet as we speak. In fact, I'm have to hop as soon as this conference is done back to the HHS conference committee. And one of the things they're interested in is how are we going to study the impact of telehealth going forward. Next one, please. And the next one. So these themes of kind of resilience and redesign, I think are key to your next couple of days here. And again, we just certainly know a very, very vivid example of how interconnected we are and how we need to approach these issues in a global way. And that we need to really revisit some of our pandemic preparedness plans. I mean, we've had pandemic influenza preparedness plans for a long time, but we've had a real world test of some of those plans in ways that we might not have imagined. So we need to really look at where were the gaps in those plans. We know how important partnership is between the public and the private sectors. Quite frankly, I think this is one of the places we need to kind of dig in and have some conversations about the role of each. We know we need that partnership, but it sometimes wasn't clear enough who should do what when it comes to testing and vaccination, and how do you maximize the parts of the system that are best positioned to do those functions. We know that the public health, like the rural healthcare infrastructure, has a lot of gaps in it, and that those gaps really show up in a crisis, and that rural healthcare needs support and attention to ensure that they are sustainable, and equity needs to be, continue to be centered in everything that we do. Equity meaning that there are no structural barriers in the way of people getting, having the optimal chance to make good healthcare decisions and to get the care that they need. Next one, please. We know that it's pretty darn clear that we are not going to eradicate COVID the way some other things have been eradicated. This is going to be an endemic disease that will be present. It will probably have some of the same seasonal patterns as other respiratory illnesses. And we just are going to need to continue to manage COVID just like we do other complex conditions. And I hear a lot from kind of physician leaders and hospital leaders that this is one of the things that's really, it's been hard learning, but really impressive learning over this last year plus. Just some of the treatment advances and the scientific advances, the knowledge of how to manage this better, get better outcomes, but also, of course, the scientific just phenomenon, the incredible accomplishment of effective vaccines produced, that can be produced and tailored quickly to meet evolving threats. So COVID is going to continue to be with us, but we also know that that other things are out there. Other pathogens are likely to emerge, and that we have got to, really take these lessons to heart and strengthen a global surveillance system and a global preparedness system, so that we can recognize things earlier, slow their spread more effectively, and to help our healthcare system stay ready to minimize the damage when the infections do spread. Next one, please. And from our side on the public health part of the partnership, being ready for health emergencies is something that we spend a lot of time on. It's sort of a hallmark of what we do. However, I think COVID showed us that being well prepared for one type of a health emergency, isn't enough, that we just had never really thought of something at this scale and this duration. And we also, have learned that, we need to be more robust and more effective in responding to outbreaks in specific settings, like nursing homes. That was just such a wildfire that burned through those settings and that population. How we deal with schools, how we deal with higher risk workplaces, just getting our playbook really much more finely honed about how we respond to localized outbreaks, as well as these more community-wide things. And, again, just taking some time to really look at our preparedness plans at the coalition level and at the institutional level to say, what do we need to buff up? What do we need to change based on what we learned through COVID? Next one, please. And in terms of rural healthcare, I think, again, just because of the stresses that were on the system, exacerbated by COVID, I think it just gives us sort of another burst of attention and energy, if you will, to come back to these questions of how do we have funding mechanisms that support core capacity better? How do we expand primary care? How do we make the whole thing more sustainable? What can we do to better support OB services in rural areas that are at risk of losing them? All that we've learned about the precariousness of the long-term care system. How do we maximize telehealth? And how do we pay attention to the hospital infrastructure and the emergency medical services infrastructure that we've just sort of assumed for too long would somehow always be there when we need them. Next one, I think we've just got a few more on sort of some of these rural capacity points, and then we'll open it up for discussion. This is kind of looking at hospital birth services specifically over the 15 years between 2003 and 2018, and it's a pretty notable difference. The number of counties that lost hospital birth services entirely, and where is the trend going from here? Where are there the next round of pressures that may further exacerbate the gap in access to OB care? Next one, please. Access to critical trauma care has been something we've worked hard to protect, and to have level 1 and 2 trauma hospitals, to have a trauma network so that all Minnesotans can be, well served by that network. And indeed, 3/4 of Minnesotans live within 60 minutes of either a level 1 or level 2 trauma hospital. And a lot of hospitals have some level of trauma designation. And 98% of Minnesotans live within 60 minutes of a hospital that's got some level of designation as a trauma hospital. And you can see there, you can't really see it in the small version, but drive times are mapped out to designated trauma systems all over the state. But the next slide kind of shows another piece of the issue. How do you get to the trauma hospitals? The rural EMS system is heavily reliant on volunteerism. 80% of rural EMS agencies rely on volunteers. And that's an increasingly fragile system. The volunteer rosters are getting smaller. Many shifts are becoming difficult to fill. 60% of EMS agencies report that they don't have enough staff to cover their call schedule without really an undue burden on the staff that they do have. And you can just sort of see the impact that has on availability or reliability of shift coverage and ability to provide, to not be able to provide paramedic level services in a great number of cases. Next slide, please. So just a quick word on resources available to work on these issues in the coming years. Minnesota is getting a lot of money from the American Rescue Plan funding. Over $2 billion is going directly to county and city governments for their flexible use in responding to some of the gaps revealed by COVID. So lots of local government funding, which we ought to have discussions at those local levels about what are the priorities for use of those funds. The state is getting over $2.8 billion in similarly flexible funds to respond, to continue to meet ongoing COVID needs, but also to respond to some of the kind of holes in the system that COVID related. And that this, of course, is the topic of a lot of conversation in the session. Not all of those funds are going to be spent this year. Some of those funds are going to be held over to the next legislative session as we learn more about what are some of the highest and best uses. And the largest part of the funds, $3.5 billion, is coming from the federal government to specific programs like hospital preparedness, or on the human services side, lots and lots of funds for childcare, for community-based services. And from the MDH point of view, significant funding coming to us, which in turn will flow to local public health for continued work on vaccines, testing, health equity. So there, for once, resources should not be the first barrier to thinking about how could we redesign things to be more effective. These are short-term funds, so we've got to use this time to figure out what is the sustainable system and how do we advocate for that going forward. Next one, please. I think I'm probably going to go fairly quickly through these last couple slides here. I think we've talked about a lot of this already. And we know that the rural healthcare workforce is already stressed and is looking at some trends that are not favorable in terms of the age of the physician workforce and the expressed intention to retire. Higher percentages of rural physicians intending to retire sooner than their urban counterparts and the like. So I think we can skip past the next slide. I think. Zora, yeah, that's just sort of the retirement. What do we need to do to kind of respond? Thank you for those of you who have played great roles in being preceptors for students. It matters to give them those experiences and all the things that we have and are committed to building on and working hard to retain with the legislature. Our loan forgiveness programs, our ability to target training for providers with integrated models and teams and so forth, and finding those innovations that are happening out there and how do we learn from them and scale them so that new models of care, integrated care, telehealth supported care, practicing at the top of license, using some of the new professions, how those innovations can be really scaled across the state. I think meetings like this are a great way to share those innovations. Next one, please. And, we at MDH will continue doing all the things on this slide. And by the way, I'm assuming that the slide deck will be available to folks to look at your leisure. So there's some detail on here just about the specific things that we're doing around clinical training and incentivizing and, some of the redesign efforts that DHS and we are doing, as well as trying to harness our data and work with the Rural Health Advisory Committee to look at what issues and policy recommendations may be most helpful. Next one. And again, health equity, just cannot say enough about the need for that to continue to be an area of learning and an area of focus and innovation, that as long as we've been talking about this and working on it, we know that the needle hasn't moved very much in terms of what produces those inequities to begin with, and working further and further upstream on the conditions that are leading to the differential outcomes, I think continues to be a shared priority of ours. This is just, again, a very detailed slide of a significant CDC health equity grant that we have, that we're just got approved for within the last couple of weeks, that will give us some new ways of working on health equity across the state. So you can take a look at this at your leisure. Next one, please. And, I think, again, not only in terms of policy, but in terms of some really concrete things about how we can diversify the healthcare workforce, recruit, but also then retain and support and grow the leadership capacity of physicians and other health providers of color across the workforce. Next one, please, Zora. We are getting back to working on sort of the administration-wide strategic plan. Governor Walz's One Minnesota plan. So we'll be talking more in the months to come about kind of getting back on a broader health agenda and a health reform agenda that can help to shore up some of the capacities in our system, but also the outcomes of our system in terms of making sure fewer Minnesotans have access challenges, and that we move the needle on health equity. Next one, please. I think we've pretty much talked about the lessons from COVID, along the way here, but just sort of summarizing, I think, the responsibilities of different parts of the continuum in the public and private sector could use some more precision or clarification. Sort of the lack of funding, certainly in public health infrastructure, but also rural health, left us some significant gaps in our response capability. We've surely seen from a new lens now how when some folks do not have access to healthcare, and when some folks do not have paid sick leave, what that leads to in terms of disease spread and the inequity of outcomes. So from a public health lens, some of those policy issues take on more significance. We've also know that our health systems in Minnesota have gotten more and more lean and efficient and running at high capacity all the time. And in some respects, that's good. In other respects, it means that surge capacity is hard to come by when folks are running that close to full speed all the time. Next one, please. Yeah, we're going to wrap here and have at least 10 minutes or so for questions, and certainly anything that's in the chat that we can't get to, we'll get back to you. So please drop a question in the chat. We'll capture those and get back to you if we can't discuss them all. But again, I just want to, if you just advance the next one, Zora, just want to thank you again for everything that you have done and will continue to do. COVID is not over. It's probably my biggest fear, that things are so much better, and when we hit these vaccine milestones and the state mandates go away, and the health advice is now just advice. It's not a rule. It's not a requirement to socially distance and wear a mask if you're not vaccinated. But we just really, really need to keep hammering those messages to folks that there still is risk out there, particularly in some communities, and that the variants are a really, really big deal. I'm going to a meeting later this morning about the Delta variant and what do we know about that, and just the amount of spread around the globe. Is going to be a continuing problem. These variants are going to continue to pop up. And it's probably just a matter of time until one or the other of them does start to evade protection from the vaccines or from the effectiveness of treatments. So keeping the public informed, aware of the risk, and doing everything that we can to just encourage vaccination, but also those other kind of known protective behaviors. I hope we've gotten a little more comfortable wearing masks, because they're probably not a bad idea during flu season either. So we can talk more about what behaviors we hope maybe can be broadened as good public health practices or other things as well. I think, Zora, we have, I think just a couple of more, I think we've talked about this, some of the changes in healthcare delivery that we really need to get back to. All things you're working on and we're working on together through the Office of Rural Health and Primary Care, but again, just with, I think, some fresh evidence of the urgency of these things to get back to some of these themes that the Rural Health Advisory Committee has been working on for quite a while. So with that, I think I'm just gonna, good, I'm on the last slide. Just again, a profound thank you for everything that you've done for your patients and your communities. I think we've got a lot to do, kind of harvest these lessons and use them to inform our going forward work together to strengthen rural health and to bring to our policymakers some new ideas for ways to protect healthcare for all Minnesotans. So thanks again. We do have probably 10 minutes or so for questions or comments if you have them. Yeah, I see one about, and from Sarah Brickman, and thank you, Deborah and Sandra, for your kind words. Absolutely, vaccine residence or hesitancy is not a monolithic thing. There are lots and lots of factors, as Sarah is saying. The I cannot say that word ever. Politicization of healthcare and science is a rather, that's been, I think, a shock to a lot of us that an infectious disease would become an ideological battleground. And yes, we are seeing, some impacts of this whole thing on other vaccines among children, and there's both just the delay that's emerged of people not getting in to get vaccine, not about hesitancy, but just because of the impact of COVID. But just this whole, like, what is driving the suspicion of science or the suspicion of vaccinations in general.
So the next one is, what are you seeing as roles for community health workers? This emerging profession responded to COVID often on their own time and without pay. They are a health equity solution.
I think it's a great point, Anne. And when we talk about the health workforce, we have to think about it in these expanded ways, that things like resources like community health workers, as you say, are absolutely a part of the health team, and we need to kind of understand what are the things that they can do and make sure that they're more fully embedded in the system and not just reliant on as you say, kind of volunteerism, kind of trying to find ways to insert themselves. The next one about telehealth. I know there are some national conversations starting about how to study the impacts of telehealth. Here in Minnesota, there's a telehealth study that the legislature is still working on. What's going to be the scope of that study? and who's going to do it. I think it'll most likely be a DHS-led study. It'll be challenging methodologically because telehealth exploded, so quickly in the last year that kind of sorting through the quality of the data is going to be something. So I think there'll be probably a preliminary report sooner, and then a longer term, kind of more complex study to actually look in a more quantitative way. So I know that part of the idea is there'll be some qualitative work of talking with folks, with providers and patients about their experience of telehealth, and from your perspective, what was good about it. But then the quantitative piece is going to take longer to pull together. Let's see. Then I see from Kim, how should the model of nursing home care evolve? Well, that's a great study. I mean, a great question. And we know, the challenges with long-term care have been around a long time. The workforce challenge is always there. It's difficult work. It's low-paid work. A lot of turnover. So how do we help to strengthen the nursing home care continuum and profession, and maybe strengthen the partnerships and the relationships between long-term care facilities and healthcare partners, so that they're not, in many ways, in many places it's great coordination. They're literally part of the same organizations, but when they're not, the fragmentation of care is really can be a real challenge, as we certainly saw within COVID.
Here's another question from Anne. How can we support efforts for technology adoption, tech education, and assistance? Up to 40% of older adults in rural areas do not use technology effectively.
Boy, that too is a great point. It's not just the technology itself; it's support to the users of technology. I think our higher ed institutions, community service organizations, groups like the Department of Employment and Economic Development. I think everybody's kind of got a role to play in understanding, the critical role of technology and the gaps that exist in, as you just said, it's not only the technical availability of it, but the comfort of people in using it. And I think that's well beyond MDH, obviously, but I think it's a kind of a society-wide challenge of how do we close those digital gaps. I think this is a time when we have to balance our level of fatigue with our level of enthusiasm for figuring out what just happened, and what do we take away from that, and how do we very quickly use that knowledge to strengthen some of these critical areas. So with that, I think we will move into the awards section of the program. And I'm really pleased to be able to hang on for a couple of minutes to join you for this. I think who's ever
got it. Okay.
Okay, yeah, I think we've got some great videos to show you here. Just as preface, the Minnesota Rural Health Awards, I'm sure you know, are given every year to individuals and groups who have made a significant contribution to improving rural health in Minnesota. And typically, normally, the Minnesota Rural Health Hero Awards are announced at the conference. And as the 2020 conference was canceled due to the pandemic, we wanted to honor those folks here with us today. And I want to thank Blue Cross and Blue Shield of Minnesota for sponsoring the creation of these videos. So the first Lifetime Achievement Award goes to Dr. Deborah J. Erickson at the All True Clinic in War Road. Dr. Erickson is a family medicine and OB physician who was born and raised in War Road, and she saw firsthand her community's really significant healthcare needs and challenges. And so after her training, she went home to serve and has served as the single longest serving physician in War Road. Dr. Erickson absolutely exemplifies what it means to be a family medicine physician by providing a wide array of services and procedures for her diverse community through generations of patients of all ages. She knows exactly how crucial it is to have local access to quality health care, and her lifelong knowledge of her community, as well as her medical skills, has given her unique expertise and has really greatly benefited her patients. In addition to caring for her patients, Dr. Erickson passes on her knowledge and her passionate commitment to rural health to med students from the University of Minnesota's Medical School Duluth's Rural Medical Scholars Program. And this is another just cool thing. The honor and satisfaction of serving her community, she has passed on to her son, Dr. James Erickson, who recently completed his medical residency and will practice side by side with his mother for an additional couple of years before she goes to her well-earned retirement. This is a great example of rural health literally growing their own. So Kim, would you play the video?
Hello, my name is Brittany Cole. I'm a regional supervisor for Altru at the War Road Clinic. I nominated Dr. Erickson for the Lifetime Achievement Award because she has selflessly dedicated her career to the residents of our community, being the only long-standing physician for our town over the last 3 decades. She is knowledgeable, detailed, and compassionate. She makes you feel comfortable and takes time to help you understand your health needs and plans. Also, not only does she provide care in our clinic, but because of our rural area, she has covered inpatient call shifts at our local hospital, which is 25 minutes away. This is measured to numerous trips back and forth in all sorts of weather, family events, holidays, birthdays being missed, as well as overnights spent at the hospital. So, for nearly 35 years, she and her family have made a large sacrifice while she has been providing care at the hospital and clinic. Our community is quite fortunate to have such a wonderful long-term physician, and we are eternally grateful. I do not know of a physician more deserving of this award. Congratulations, Dr. Erickson.
I am Dr. Deb Erickson from War Road, Minnesota. I grew up in this beautiful area, and the one concern I had, even in grade school, was our inability to maintain consistent medical care locally. Doctors would come and go every 2 to 5 years. We barely got to know them, and they were gone. This was my inspiration to become a physician and return to War Road. I have now provided almost 35 years of consistent care, which makes the entire community healthier. My son, Dr. James, recently joined the Altru War Road Clinic and plans to have a lifelong practice here also. The two of us are a perfect example of why it is so important to accept medical school applicants from small towns in Minnesota. I feel extremely honored to be chosen for the Minnesota Rural Health Lifetime Achievement Award. Thank you.
Well, thank you for your service, Dr. Erickson, and what a great legacy to pass on to Dr. James. And we're thrilled to hear that he plans to give the same level of commitment to his home and yours. So thank you so much for this well-deserved honor, Lifetime Achievement Award, indeed. Thank you, Dr. Erickson. The 2020 Minnesota Rural Health Hero Award goes to Dr. Kim Kruger. She is a family medicine physician who was drawn to the field of rural healthcare as early as high school, and it has remained her focus throughout her professional career. Once out of medical school, Dr. Kruger spent 4 years as a family physician in Buffalo and then 9 years as a family physician and educator at the Duluth Family Medicine Residency Program. The last of those years were first as the associate and program director. When the College of St. Scholastica decided to create a new physician assistant program, Dr. Kruger's interest in rural health, medicine, and teaching made her the perfect candidate to help launch and develop an accredited program that could address the shortage of primary care professionals throughout the state. Dr. Kruger has a reputation not only for teaching students the essentials of medicine, but also for developing compassionate and patient-focused providers who will help provide quality healthcare across Minnesota into the future. Please roll the video.
My name is Bria Shirky, and I'm one of many of Dr. Kruger's hundreds of PA and medical students that she has nurtured and mentored over the past many years. We are honored to nominate Dr. Kruger for the Rural Health Hero Award for her role in teaching all of us and inspiring us to provide compassionate care with kinship and kind of deep love for all of her patients. Dr. Kruger has this uncanny ability to find the best in everyone she meets and inspires us to be our best. So we are grateful for this opportunity. Thank you, Dr. Kruger, for being an incredible mentor and teacher. I can't think of a better person to receive this award.
Hi, my name is Kim Kruger. I've been working to support rural communities my entire medical career. I'm passionate about rural health because I believe quality medical care should be available to everyone, no matter where one lives. I'm most proud of the hundreds of medical providers I've helped train over the years. So many of them have chosen to practice in rural communities. I'd like to think I was part of giving them the skills and confidence they needed to provide top-notch care in these often challenging settings. I'm so proud of all of you.
Well, thank you for your dedication and innovation to address the shortages of primary care professionals throughout the state, Kim. It's clear that your students admire and respect you and are picking up of your invaluable teachings to practice them. Congratulations. The 2020 Minnesota Rural Team Award goes to the rural family medicine preceptors in rural Minnesota and western Wisconsin. The shortage of rural physicians is a problem not only in Minnesota, but it's a well-known challenge across the country. Since 1973, more than 400 community physicians have voluntarily taught first and second year medical students through their educational tenure in Duluth. The number of volunteer hours donated by these physicians is well over 300,000 hours. Kim, please play this video.
Hello, my name is Emily Onello, and I'm honored to be giving the Rural Health Team Award to our family medicine physician preceptors from Minnesota and Wisconsin who volunteer to teach our medical students from the Duluth campus of the University of Minnesota Medical School. My colleague, Jim Bolger, whom many of you know, celebrated, quote, the powerful impact these physicians have had on our students, unquote. Students in Duluth are placed in rural communities under the tutelage of family physicians for 5 separate weeks during their first 2 years of medical school. The family medicine physician offers to house the student and incorporate her or him into their life as a family physician. With this model, our students gain an excellent and accurate picture of practice and home life of the rural doctor.
The University of Minnesota Duluth, they focus on rural healthcare from the very beginning, from day one of medical school. I was fortunate to participate in the RPAP program, which is a rural physician associate program where we spend 9 months in a rural hospital. And it definitely solidified my calling to rural family medicine.
Across the U.S., only about 5 to 7% of physicians practice in rural areas. Of the students who have begun their studies in Duluth and completed their training, 44% practice in communities smaller than 25,000 people, a remarkable standout against the national averages.
In the state of Minnesota, a lot of our population lives in a rural area, and we value that. And I really hope that we can continue to value our rural health care so that this huge population that does live in the rural area can continue to receive care at their local hospital. Being in a rural area, it is extremely hard to recruit doctors to come back to these rural areas. It's been extremely rewarding to make such a difference in people's lives, whether it's through delivering a baby or taking care of an entire family or caring for elderly. People are just extremely appreciative, and I've just found that going into medicine has just been a perfect fit for me.
Since 1973, the medical school's mission has been and remains to train family and Native American physicians to serve our rural and tribal citizens. Dr. Bolger reminds us to, quote, imagine, if you can, what the effect would be if these physicians had not been willing to help to sacrifice professional and personal time to assure our rural citizens of a competent and satisfied workforce for rural Minnesota, unquote. Thank you, rural family medicine preceptors, and congratulations on your well-deserved Rural Health Team Award.
Thank you, Dr. Onello, for presenting that. And thank you to the hundreds of preceptors and to the University of Minnesota Medical School Duluth's Rural Medical Scholars Program. What wonderful work and what a huge difference it's made to the people of our state. I want to just say another word about Dr. Jim Bolger, who you heard referenced there a couple of times. Dr. Bolger was our 2014 Rural Health Hero awardee. He was the director of the Family Medicine Preceptorship Program and the co-director of the Rural Medical Scholars Program for decades. I'm told long enough to have had both Kim Kruger and Deb Erickson as preceptor students. He has recently moved into the Distinguished University Teaching Professor Emeritus role. His lifelong career teaching and his inspiration of students to practice in rural health has had an immeasurable impact. So we want to thank you again, Dr. Bolger, for your service. I want to thank all the nominators for these awards too. It takes time and effort, and you can see the respect and the affection that the nominators have for the people that they nominated and the such deserving award winners this year for our Rural Health Awards. If any of you know of a rural health hero that you'd like to nominate for 2021, please visit our website, complete a nomination form. Those forms are due by Friday, August 27th, and will be announced on National Rural Health Day, which is November 18th of 2021. And with that, I'm happy that I got to spend a little time with you this morning and look forward to seeing many of you in person sometime soon somewhere. Stay well, and thanks again for everything you do.